let's talk about disorders of red blood cells. And red blood cells, as we know, the other name for this are erythrocytes. Your laboratory workup will reveal the values as following for men and women. Men have higher content of hemoglobin than women, and again, every facility may have slightly different scale for labs, but usually they will follow these numbers fairly closely. So men have 14 to 16.5 grams per deciliter, while women will have 12 to 15 grams per deciliter. It's possible to call men anemic, let's say we'll say 13, while women will be considered within normal range. Hematocrit is the amount of cellular material that comes out from spinning the blood in the tube, basically in centrifuge, and whatever is the sediment type of material. So men will have 40 to 50% of hemoglobin, and women 37 to 47. Again, bilirubin can be measured as byproduct of the hemoglobin breakdown and red blood cells breakdown, and it's usually 0 to 1.2 grams per deciliter. But that's an important lab to show the liver function, or anything else can be going on with hemoglobin and in the body. So again, these are the three important labs for blood. I would like for you to remember, and you can look at this yourself and say the ratio of normal hemoglobin to normal hematocrit is 1 to 3. Let's say your patient had hemoglobin of 14, and 14 times 3 will be 42. So you can see that lower level in men is 40. So approximately 1 to 3 ratio. If that ratio is higher or lower, that may signify changes in the blood, such as dehydration or excessive fluid volume. Again, if the hematocrit is higher than 1 to 3, that means you have too much blood cells and too little water. If hematocrit is lower, that means that you have too much water and too little red blood cells. MCV is mean corpuscular volume. It's the size of the cells. MCHC, mean corpuscular hemoglobin concentration, it's the concentration of hemoglobin, and MCH is mean cell hemoglobin. MCHC and MCH, they both reflect the color of the cell, and MCHC is more commonly used, but the more concentrated hemoglobin is, the more red it will appear. The blood will be more red appearing, and it's possible to measure. And RDW, it's red blood cells distribution weight. Some of you took statistic, but without going into statistics and talking about distribution weight is the difference between sizes of the cells. If the distribution is wide, it means we have variety of the sizes of the cells, from very little ones to relatively large ones. If it's narrow, means they are uniform and they are normal. So wide distribution or increased number here will reflect that you have variety of the cells. variety of the cells usually means that you are bleeding and producing rather small or even immature cells trying to replenish blood loss quickly. So you want this be relatively narrow or a small number, the cells being uniform. Anemias. Anemias. This is the language of anemias. Normocytic, macrocytic, and microcytic. This relates to the size. And by size, we mean mean corpuscular volume. So if it's normal size, but patient still anemic, means hemoglobin level is low, then it will be normocytic. Macrocytic, the size of cells is huge. Microcytic is the cells are small. So you can say microcytic anemia, macrocytic anemia. Normochromic and hypochromic are related to the color or hemoglobin concentration in this case. So normochromic, normal color, hypochromic, hemoglobin isn't concentrated, or hemoglobin is pale. So you can say normocytic, normochromic anemia, or macrocytic, normochromic anemia, or microcytic hypochromic anemia. You can use these words together all the time depending on the size of the cells and depending on the color of the cells. And there is no hyperchromic definition because without going into too much detail, you just can't have too much color in red blood cells. So it's usually normal to hypochromic. Different types of anemias pictured on this diagram. Iron deficiency anemia will be when the cells are small because we don't have enough iron to make big cells or normal cells. Megaloblastic anemia is when the cells are huge, megaloblastic anemia, and it's usually B12 or folic acid deficiency. And big cells are dysfunctional, so you can have big cells but you still won't have enough sufficient number of them to carry the oxygen carrying capacity, or they may have lower the oxygen carrying capacity whatsoever. But sickle cell disease, cells are sickled in the crisis and they can stuck in places that they are not supposed to cause sickle cell crisis and pain and also ischemia. In normal cells, you can see it's like you just went to Dunkin' Donuts and brought a box of donuts and they are laying around waiting to be eaten, and there is an indentation in the middle which is roughly comparable to the side of the cell. That's how it would look. So the hole in the donut, the diameter of the hole in the donut is equal to the diameter of the side of the donut. Picture it like that. So that normocytic anemia, and you see sufficient size. They are not too many, but they kind of overlap, and that's the normocytic normal size of cells. Okay, this just describes the size of cell. You really cannot tell how many, or is it anemic or not, but most of the time megaloblastic or iron deficiency small cells, you see that they are too tiny even to have the indentation in the middle, although of course there is no nucleus. Causes of anemia: blood loss, stabbing by the knife and losing blood, versus blood loss, let's say from cancerous small tumor in the gut that bleeds continuously, hemolysis, breakdown of the cells extensively, and impaired production, impaired synthesis. So the last one, of course, is when the bone marrow is impaired, can make enough cells. When we have iron deficiency anemia, and it's often caused by blood loss, again, it's slow bleeding tumor, wound, injury, can be even surgical wound. Patient lost some blood during the surgery, so but this is very clear-cut cause. In iron deficiency anemia, patient will have microcytic hyperchromic anemia with increased RDW because they're losing blood, but they still have normal sized cells, and there are lots of new cells in circulations which are relatively small, and RDW will increase because of that. And it will be hyperchromic because the new cells are pale. Megaloblastic anemias are B12 anemia, which is another word is pernicious anemia, and folic acid deficiency. B12 anemia is notorious, or alcoholics are notorious to develop B12 anemia because impaired absorption of B12. Also, people with impaired GI production of intrinsic factor may have B12 deficiency. This can be resolved by, for people with alcoholism in acute state, intravenous injections of B12, but for someone who just missing intrinsic factor necessary to absorb B12 from GI tract, by intramuscular monthly B12 injections. And folic acid is easy to correct by oral administration of folic acid. So both of those deficiencies will result in increased cell size, and B12 deficiency interferes with DNA production and increased size of the cells, which are not effective. So that's why patient anemic. Aplastic anemia, again, bone marrow depression. Basically, we can't produce too much because we don't have facilities. And chronic disease anemias, chronic inflammation and chronic renal failure. Let's talk about the second a little more. Chronic renal failure is resulting in decreased erythropoietin production and decreased stimulation of the bone. So in this case, we will have normocytic, normochromic anemia because our bone has normal producing capacities of the anemia. Our bone has normal producing capacities to produce red blood cells. Our bone has normal capacities to produce red blood cells. However, we don't have enough signaling to encourage that production. Iron deficiency anemia, again, hyperchromic and microcytic, and the cells will look pale and small. And polkiocytosis also may result, irregular shape. Anisocytosis, it's irregular size. Again, this is just the consequence of having not enough iron or hemoglobin to produce the cells. The cell in the middle is subtype of white cell with granules, so that's not the iron deficiency. Iron deficiency anemia, you can see anisocytotic cells and polkiocytosic cells present. Small cells, they are rather oval, or they don't have that donut indentation in the middle. Megaloblastic, huge cells. Again, folic acid deficiency or B12, I talked about it. Pernicious anemia, again, B12 deficiency, secondary to absence of intrinsic factor, which is necessary for GI absorption. And again, the cells will present the same way. Is it folic acid or B12? You really cannot tell by looking at the cell. But the red cells will be huge, oval shape, poikilocytosis, and anisocytosis cytosis, and this will be like somewhat like oval or teardrop shaped cells. Hemolytic anemias are membrane disorders, and one of them is hereditary spherocytosis, and acquired hemolytic anemias can be something like a drug may cause hemolysis and hemolytic disease of the newborn. So hemolytic disease of the newborn again was may result in excessive deposits of bilirubin under the skin because excessive presence of destruction, because of the excessive destruction of fetal hemoglobin, and the newborn will turn yellow. It's one of the first nursing interventions performed regarding this disorder in 19th century in England. And what happened, one of the nurses was very diligent about the fact that fresh air and sunlight will be only a benefit to everyone's, and she would take all the babies, especially the ones who turned yellow outside, and lay them under the sun. And eventually the babies who were under the supervision of this lady were losing the yellow tinge and were developing better than others in other hospitals or wards. So one of the physicians actually wrote a paper and presented that phenomenon. However, the use of phototherapy wasn't widespread until 20th century, and nowadays you will see the ultraviolet lights in the nursery where the baby can be placed and have their own personal tanning bed and get rid of excessive bilirubin. Excessive bilirubin, of course, destroyed by ultraviolet light, so ultraviolet light will help to combat this. Again, to deal with consequences of hemolytic disease of the newborn, it's the best way so far to do is using phototherapy, sunlight, or ultraviolet light. Of course, in moderation. You don't want sunburns on baby or anyone else. So please do it under supervision, and do it if only if prescribed. Hemoglobinopathies and thalassemia and sickle cell anemia. Sickle cell anemia may result as a change in the shape. Sickle cell disease, so it's a mutation in beta chain of hemoglobin. So if hemoglobin is severely deoxygenated, and I shouldn't use word severely, it's just deoxygenated, beta chain links, they just clamp together. They will become a long protein rod that will kind of stick through the cell and make it sickle. Basically, imagine you stuck a rod through the balloon and it's stretching it, turning into like football. So when this happens, these cells cannot travel and they're getting stuck. They cause strokes, retinal infarcts, stuck in the eyes, in lungs, and they can even block the blood flow to bones. A vascular necrosis of femoral head can happen, and also they cause painful infarcts in extremities and fingers and toes. Secondary to ischemia, of course, pain occurs, and in skin, because of not enough oxygen supply, the skin ulcers will occur. The spleen will have eventual atrophy, and also chronic kidney disease will develop. Blocking the capillaries by sickled cells will result in acute pain. Infarctions, again, will cause damage to most of the vital organs, and it's somewhat related to diabetes damage, but of course the mechanism is completely different. But this is also end organ damage, and diabetes of course doesn't affect everything to this extent. So sickle cells are being destroyed extensively, so patient may develop jaundice as a result. People who have only alpha chains, or people with some fetal hemoglobin which has only alpha chains and gamma chains, are protected from sickle cell disease because neither alpha or gamma can sickle. Only beta chains can do this, and only beta chains can sickle. So some people will have certain amount of alpha and gamma chains hemoglobin. Gamma chains is a chain specific for fetal hemoglobin, and that's why they won't have sickle cell disease to that extent, even if they have a trait for it. Thalassemias are defective chains of hemoglobin, and this results because of there is a defective gene for alpha chain synthesis or defective gene for beta chain synthesis, and depends how many genes are involved, the severity of disease may happen. And when you compare alpha and beta, just briefly, you will notice one interesting phenomenon. Of course, fetal hemoglobin doesn't have beta, and that's the reason that alpha thalassemia will affect both fetal and adult hemoglobin, and in beta it's only affect adult. So people with Asian descent may develop alpha and beta thalassemias are more prominent in people with Mediterranean origin, such as Greek and Italian. The variety of disease presentation or clinical manifestation may be quite wide in these disorders. So patient may be severely anemic and present with the need for transfusions, while in other cases there will be essentially no clinical manifestations for these people. So alpha thalassemia may result in newborn, and in newborn this can be quite severe manifestation. So when all the alpha chains are deleted and the patient only has, or baby only has gamma chains, or this is fetal hemoglobin, the HB BART created, so gamma 4 hemoglobin created, and gamma 4 unfortunately has strong affinity to oxygen. What will happen, it will capture the oxygen molecule, but it will never release it to the tissues they need it. And if this happens, unfortunately, this may result in death in utero or shortly after the birth. because this is again inability to transport oxygen. And in beta form, sometime patient would need transfusion. Sometime patient may need even phlebotomy therapy, because they need to get rid of defective hemoglobin. And so bone marrow transplant may result in the cure of some patients, but again, variety of the clinical symptoms in both disorders may vary depending on the number of the genes occurred, and some consider that these are not real anemias, but also this can result as a real anemia with hemolysis. But again, treatment may vary, and from the manifestation also can vary from death in utero or shortly after birth in severe alpha disorders versus quite in uneventful clinically course for people with beta hemoglobin deficiencies. So, and this concludes the lecture for blood disorders, and please contact me if you have any questions.